everybody. My name is Dr. Arun. Welcome to another episode of Success Beyond Scales, a podcast that we have been running very regularly. The whole premise of which is to educate, to empower, and to enable individuals who wish to live healthy, purpose driven, and meaningful lives. Today's topic is going to be exceptionally interesting and thought provoking because what we are experiencing at the moment is almost like a medical revolution. And this revolution is struck by the so called wonder drugs, which are called the GLP-1 medications. I'm sure most of us who are listening to this webinar or podcast would be familiar with Ozempic, Wegovy, Monjaro, and the likes. And we keep hearing headlines after headlines in the news for the right reasons and also for the wrong reasons, some of which we will delve into today. But the whole premise that we are hosting this webinar is to gain meaningful information on how we can use these wonder drugs or GLP-1 medications in order to achieve lasting health and wellness. On today's webinar, I have got two brilliant minds with me, and they are going to be sharing with me their experiences. They are medical practitioners who I'll be introducing very shortly to you. And essentially, the whole premise of this webinar would be to ask these experts, these brilliant minds who are here today to take some of the questions. I've already received some of the questions, and I'm going to essentially pose some of my own questions that I get asked by my own patients. Now, in full disclaimer, I'm a bariatric surgeon, but I do not prescribe these medications because I believe it's a very specialized field and we need to tap into the wisdom and the experience of experts. So our first expert today is Dr. Don Zhange. Dr. Don Zhange is a bariatric physician. Don, I'd like you to come turn on your camera. He's a bariatric physician who integrates both medical and surgical approaches to obesity management. He works closely with many specialties and specialists and leads a multidisciplinary clinic which is dedicated to long-term weight loss successes. Welcome to this podcast and webinar, Don. Really appreciate your time. And I'm sure there will be a lot of questions coming your way to see how, as a GP, you see this problem not only in a general practice, but also the questions that you get in your specific work as a weight management physician. So thank you, Don.
Thank you. Thank you, Arun, for having me.
Pleasure. And our second specialist is indeed a brilliant mind. His name is Dr. Roland MacCallum. He's an endocrinologist at the Royal Hobart Hospital, trained at the University of Glasgow, Scotland, and moved to Australia in 2007. And he has interest in weight management and diabetes. But how I came across Roland and how the whole premise of his work intrigued me was that his practice, he was the founder of what is called as brilliant minds, or brilliant beings, sorry, not minds, brilliant beings. And I'm really curious to see how Roland brings this integrated approach, because we know that it's not just about weight loss, it's about creating a total transformation for the individual who's on this journey. So, Roland, welcome to this podcast. Thank you once again for your time and truly appreciate that background as well. I love that brilliant being background. So, thanks for coming on board, Roland. So, let
Thank
me
you.
just get straight into it, Roland. I'm curious to know, firstly, from you, what's the premise of this brilliant being? Where did this start
Um,
from?
it's an interesting story. So I was working in a silo as an endocrinologist, seeing lots of diabetes patients, weight management patients, thyroid patients, but I was working on my own and was dissatisfied with sending people off to see dietitians, diabetes educators, and not working in the same cohesive unit. And so 2 years ago, we set up Brilliant Being, where we have nurses, diabetes educators, psychologists, endocrinologists, and some GPs who are specialists in weight management. And it's all to work together. We have team meetings. But the premise is that rather than telling people, you have to do this and you have to do that, it's recognizing that people are brilliant beings. They're maybe not feeling it at the moment. Maybe their diabetes or their weight has gone off. And our job is to try and make them feel a healthier and happier version of themselves.
Great, great. And I think what I'm seeing is the word brilliant being incorporates a holistic approach. And what you have created seems like a multimodal one-stop shop for individuals who are looking at getting all those resources from one place.
Right, that's right. And because I think it's difficult for patients when they're trying to find people and provision of services that they can trust, that people will be joined up in their care rather than this is my area, and we actually don't talk to each other. So to be able to work together with other professionals in these areas is just wonderful. I thoroughly have enjoyed doing it this way rather than just being in my own little box. And I think it works better for patients.
Yeah, absolutely. Don, I'll come to you. And I know you have your foot in both camps, surgery as well as medicine. So tell me, in your estimation, do you see that we are already witnessing a decline in bariatric surgery numbers across the globe? It's not a national phenomenon, it's a global phenomenon. But do you really see, where do you see a role for bariatric surgery as a physician and a person who has got that surgical insight as well?
Yeah, I think the bariatric surgery is here to stay, and that's definitely a definite thing.
I'm
Over
recording
the
this, by the way.
years, over the years, we have had a great evidence on how well the surgery can work with the Swiss study, up to 20 years of data that showing that it's both safe and effective tool of working of helping people with obesity. And as Roland has highlighted, and as all of us know, that obesity as itself is a very complex disease. It's never needing one person, one thing to fix it. You really need a whole team around you and lots of different ways of helping or of treating obesity from different angles. In the dietitian from the diet side of things, exercise physiologist, the physician to help to curb the hunger. And luckily now we're really lucky in a in era that we actually do have an effective tool on that side, and of course surgical side of things to both help from the anatomy and the hormonal side of things as well.
Yeah.
So I think surgery is here to stay, and it will have its role in the new world.
Very good. I think many bariatric surgeons listening to this would get hope from that, definitely. But I guess my point to you is, are there certain patients that you would see or certain individuals that you would say, you are not suitable for GLP-1 medications. You need to go straight. Who are those people? Just for the benefit of whoever are listening to this live, and there are people who are listening to this live as well right now. What would you say, who are those patients, that you would say, don't waste your time with GLP-1s. You need to consider surgery.
Um, Definitely with GLP-1s, I suppose it's a really hard question to answer because everyone literally can have a trial for GLP-1 before surgery. But it all depends on what side of area you need help with, and what can the surgery bring to help in each individual cases. So I think that's very important for the patient to have a conversation with their doctor about what their need is, and so that to find the right tool. For example, if someone that's got a really high BMI with a really high risk of sleep apnea and diabetes, then probably a short period of GLP-1 before surgery will be a good idea. Also, that long-term point of view, you really have to think about getting the long-term the long-term plan in place rather than just not looking for the next couple of weeks, couple months or be a couple of years. So realistically, what's the better solution for the patient itself? Are they willing to continue on the injection for indefinite period of time, or they rather having one simple surgery to help them can achieve the similar thing? So I think that's
Yeah.
probably the a decision between the patient and the doctor.
Yeah, I think, yeah, and that's another point that we will touch upon. But just I'll come to Roland. Roland, do you see some patients? I think what Don has touched upon is a bridging therapy for bridge to surgery, which is a different class because I think their path is more towards surgery, and GLP-1 is being used to optimize their sort of, physiological status to get them ready for surgery. But are there any patients that you come across who you would say, you know what, unlikely that you would benefit from GLP-1s?
We all come from our own bent, and therefore, I intuitively want to give people the opportunity to avoid you, Arun, and your like. So, I mean, lots of people now come and say, "Oh, we prefer not to avoid surgery."
Yeah.
But you're right. I mean, there are I think a small number of people. I mean, there's the obvious contraindications. So if somebody has major issues with pancreatitis, which is a very, very rare complication associated with GLP-1 use, um, and they're not going to be suitable for it, or if they've tried it in the past, or if they've got significant gallbladder disease, or there's something else going on that, they've got a very unusual thyroid history, then perhaps you might say, well, look, we can use other drugs, but we can't use the GLP-1 drugs. And therefore, it might be sensible for you to think about medication. Even people, however, with the most complicated kind of obesity that Don's talking about, BMI might be over 50 or 60. I mean, I remember last year, we had a 310 kilo fellow who came to see us
Mm.
and really struggling. Fascinating story. At the age of 5, he remembers going to birthday parties, and his mum would say the only way he would stop eating was when he started vomiting.
Yeah.
He did not have that feeling of satiety and so on. And so throughout his life, he's now a chef. And he would come back home at the end of work and he would just start eating and eating and eating, and now I knew that we put him on a GLP-1 and we put him on another agent called Contrave to try and help with that satiety. And it was wonderful the day he came back to me and said, Roland, I can actually feel full. I wanted to stop eating my dinner the other night, and I haven't felt like that for years. I mean, it was absolutely wonderful. But even with that, he managed to lose 60, 70 kilos. He's still sitting at
Which is not enough.
240. No, so he's still sitting
Yeah.
at 240 with his diabetes, with his sleep apnea. And so again, he always knew from the start, we're going to be speaking, and we liaised with one of the bariatric surgeons that we work with.
Hmm.
So I think there are very limited areas that we wouldn't use it unless there was a contraindication or the patient was against it. Otherwise, I think it's combination therapy, as Don said, because the two work hand in hand. And we see that on the other end. When people go through bariatric surgery, they often also require GLP-1 use as well to be
Correct.
able to maintain it. We often get patients sent back to try and help because of the food noise or the other issues.
Yeah, that's spot on,
So
And
I
I think,
think just
yes,
to
Don.
sorry, to further elaborate on Roland's, look, the other things that I've been seeing a little bit more and more actually now is that people who have tried GLP-1 and decided either not to willing to go on or not getting enough restriction or of satiety or result from the GLP-1 itself, and willing to go on for surgery as well. I think that's probably the other trend coming back on, and everyone is kind of rushed into the idea of GLP-1, and again that not getting the satisfaction at the end of the day, because the potential for GLP-1 is still not as great as surgery of weight loss. They tried it and turn around to seek surgery. I think that's probably the other side of things I'm seeing a bit more, rather than trialing GLP-1 again. than just go straight for surgery. I think that's probably really highlights that the GLP-1 and the surgery are here to work together, not sort of against each other.
Absolutely, Don. And I think you're right. The referral pathways seem to have changed because, like, people used to try diet and exercise before they would consider other more serious options. Now they're saying diet, exercise, and GLP-1s. Let's see how this goes. Which brings me to another question. And in fact, before I go to the question, Roland, I completely agree that, I've seen several such patients who have come to see me eventually, but what they said was that the GLP-1 just turned that switch, the hunger, the food noise switch off. So exactly as you're describing about this patient, the one that you just mentioned, who's a chef now, like the food noise, and they've never experienced this. It's a totally new experience for them, which is something that GLP-1s have really sort of, we've heard this time and time again. But the one question which I've got, which has been posted just now, is GLP-1, and by the way, I would encourage the audience or people who are listening to this live to please put your questions in the chat box so that we can sort of put it to our experts. Is GLP-1 a forever drug? Is this something that, just like blood pressure, just like a statin, or for diabetes, whatever you may say, this is a drug that you have to be on for the rest of your life? You cannot get off. What has been your experience so far with Brilliant Being and before that, Roland? And I'd like to ask Don as well.
Well, it's a great question, isn't it? You go to see some of these wellness gurus, or you watch your Instagram and so on. Or if you go on your GLP-1, lose some weight, keep your weight down for a couple of years, you'll be able to reset your set point. You'll be able to come off your GLP-1 and everything will be rosy in the garden. That's not the reality, because this is a chronic condition where, unfortunately, the brain and the gut have deteriorated to an extent that you have this mismatch between the amount of energy that you take in and the amount that your body holds on to. I normally use the analogy of asthma. If I give you some inhalers for your asthma, you would expect it to get better. If I then stop them, then it'll get worse. Unfortunately, I think it's the same for the body, in that if you for the weight management, if you start one of these agents, you will get some benefit, we hope. That will be sustained while you continue on it. And most of the evidence is that if you go off these agents, within about 18 months, 24 months, you'll be back up to roughly the same weight. So I think you do need to stay on some agent, but we talk about different ways of thinking about it. So there's the weight loss phase, where patients normally need to be on higher doses of the GLP-1. And then when they come to weight maintenance, they're able to normally reduce it. Prior to the last year or 18 months or so, I did talk to patients about the option of going off treatment, and then if their weight started to go back up. You get this with a lot of going back on it. You get this with a lot of younger people, 20s, 30s. They don't want this idea that you might need to stay on it for decades.
Correct.
So, but the disappointing evidence so far is that you may go off it and then go back on it, and then it actually is far less effective than it seemed to be the first time. And I'm sure there's a lot of things at play there, but it is not the experience that you go back on it and everything works just as it did the first time. So I think we have to be very cautious about going off. You may have to stay on. I suppose the other thing to think about is, it's not that these are the only drugs that are ever going to be. We've got new drugs in the pipeline. The hope would be that, okay, you might be on your semaglutide or your tirzepatide, your Ozempic or Mounjaro at the moment, but perhaps in 3 years you'll be on the next agent, or 5 years the next agent. 20 years ago, when I remember giving Byetta, that was exenatide, to patients with type 2 diabetes, you had to give the injection twice a day. It didn't have much effect on weight, but it did bring your sugar down. And then we got to once a day, and then we got to once a week with Trulicity, and then finally Ozempic came along, and we started to see the weight reduction effects. So the hope is that things will continue, and who knows what the future is. However, I think you probably do have to stay on some agent, would be my answer.
Exactly. And they are talking already about patches and oral medications, oral GLP-1s. But let me ask Don. Don, what do you think? Is this how you set your patients up that look, this is a forever drug? Yes, the dose may vary. And of course, there is talks about microdosing and all of that. And when do you re-intervene? Because as Roland said, and we have seen this already in surgery, that first surgery has got the most effective impact, right? But then you go to revisional surgery, you don't have as much weight loss. That's not as effective as the first sort of surgery was. So over to you, Don. What are your thoughts?
Yeah, look, I think the revolutionary drugs of the GLP-1 or the new generation of GLP-1 like semaglutide, it really sort of highlights the importance or really for us to opening our eyes saying that the obesity is not something, it's actually a it's a hormonal driven event rather than just people eating too much, not having enough self-control. They just need to do more exercise and really sort of change the landscape of how we actually face obesity. And we know because a GLP-1 is a hormonal agonist that essentially trying to increase the ones that our body is not getting enough or try to reduce the appetite from that way. Therefore, not taking the medication, that suppression will be gone and your appetite will return to normal. So if therefore you really need to talking about, as Roland saying, the weight loss phase with the medication and the maintenance phase as well you really have to look at the maintenance with something, either being medication by itself or your good ongoing diet change, exercise. You have to do some changes. Otherwise, everything will go back, as again, as evidence says, everything will go back to square one. Whenever you stop the medication, everything, all the weights will go up. So really, that's sort of a message we need to get across to the patients from the beginning, saying that you really need to have a long-term plan in view, either being continue on the medication or some other way to maintaining it. And without the medication, the hunger or the appetite will definitely return.
So
So just unlike like surgery, of course, that's there forever.
yeah, but I
Yes.
mean, we know that the effect of surgery also diminishes. But on that note, I've got a question from one of the audience members is that they've had previous bariatric surgery, and I know, Don, you've highlighted the emphasis on the lifestyle modification as a key element to be able to maintain the weight. Either you are disciplined and committed, or you continue with your medication. This is how I've come to understand. But the question this person is asking is they've had a gastric bypass previously. They are very close to their healthy weight range, but they are still struggling to lose that 10 kilos, last 10 kilos. Is this something, and they are almost 2 years post their gastric bypass, lost about 37 kilos, otherwise very happy and healthy. Do you recommend that they should be going on? If this person came to see you, would you recommend taking GLP-1?
That's a very difficult question to ask, to answer, because you really need to have a real good conversation with this patient about why the last 10 kilograms. They could be coming from 200 kilograms, now they're 110 and they want to reach to 100, versus they start with 120 kilograms, now they're 90 kilograms and they want to go down to 80. So it's all about the
Their starting
benefit of the
points, yeah.
medication and the starting point, and then the real expectation coming out of the medication as well. But in general, GLP-1 can really enhance in a way of a weight loss surgery, either being a sleeve or a bypass. And from what my experience is, there's no evidence behind it, but I'm sure we're doing more research on it, that you actually need a slightly lower dose of GLP-1 to be more effective. Excuse me, to have the similar efficacy than someone who haven't had surgery in the past as well.
Yeah, absolutely. Roland, this other question is for you. And this is coming to, one of the other challenges that comes from giving these medications long term, which is the cost, right?
Mm.
Studies after studies are showing now that many of the patients who actually start on these medications, half of them drop, almost 50% are dropping off within 6 months. I'm talking purely about the cost issues, you know. How do you see when you are setting up a patient, as you gave the example of the asthma problem, that you got to keep taking this? And we know that a lot of these medications are not on the PBS at the moment for weight loss, anyways. How do you see? Yes, there is a lot of talk about the cost of these medications coming down, but let's be honest that the big pharma are also sort of, looking at their own interests and their own balance sheets as well. So, what is your view about cost and long-term continuation of these medications, and how that's going to play out?
Yeah, I deal with this question every day, multiple times, as we talk about different costs and how we can afford it. And are we going to do it the way that the TGA recommends, or are patients going to try and microdose, use small number of clicks of the pen? I mean, there's no doubt that the more competition that there is, the better. I think it's quite interesting. So Surmount 5 came out, the big trial, head-to-head, top dose Manjaro, 15 milligrams versus top dose Wegovy, 2.4 milligrams. Average weight loss with Manjaro, 21%, 15, 16% with Wegovy. Suddenly there's a shift. The top dose, 2.4 milligram Wegovy pen, comes down $100 in price. Fascinating, because there's no doubt that Novo Nordisk felt a little bit of pressure. And yeah, Mounjaro is now the most, it's the biggest drug worldwide. I think it's about 900 billion compared to semaglutide, Wegovy's 700 odd billion annual income. I think competition is likely to be good. I think we use every option that we can for the patient to try and make it doable for them. And although the PGA will not agree with that, that's one option that some patients may want to take. And every prescriber needs to work out whether they're comfortable doing that. I always say to patients, even if you can only afford a really small dose, it's better to stay on a small dose than go off it. And even if you're losing some of the benefit that you had at a higher dose, if you can continue, maintain, and often for patients that's $50 to $100 a month, which is not nothing either. Even at that rate, they may be able to continue having some benefit until the next comes along or there's reduction in price. So I think it is for the long term. I think it's really difficult for patients because they don't get it funded. And at the moment, we're just piecing it together as best we can, doing it in as cheap a way as we can, and encouraging people not to lose the benefit. Because I think the other side is people go off and then they come back a year, 2 years later, and look, it's another 20 kilos up. And now we've got to try and bring it down. And so changing the conversation from, oh, I'm not getting any more weight loss, to actually, you've made success here. You've kept your weight the same. The natural history of this condition is that it will go up your weight. So if you can maintain your weight at the moment until the next agent comes along or life changes in some way, good. And so it's trying to change that conversation so that you give patients hope, because so often it can be depressing that they don't see any further light at the end of the tunnel.
Yeah. And I think, Roland, you bring a very valid point. I guess the question, becomes that are these medications just working on your appetite, or are the individuals actually changing their relationship with food? Because I get this very often from my patients who come to see me in the clinic that, oh, I've gained a bit of weight because I've not been exercising. But we know that exercise only contributes a very tiny portion, in fact, just 10 to 15% of your total energy expenditure. Majority of it is coming from what calories and where those calories are coming from.
Well, I think it's interesting when you look at some of the factors that best predict your ability to maintain your weight loss. I normally say to patients there are three big ones. One, you weigh yourself every week. Crucial, because if you don't, you'll bury your head in the sand and you'll forget what's going on and you'll just take some weeks off, and that's inevitable. But we do need some accountability, and that's either individually or with someone else. Number two, most individuals that keep their weight down will be active for more than an hour a day. Number three, it's the whole mindfulness in eating. So when you're sitting down, don't sit at a table, don't have the TV on, don't be scrolling, eat slowly, chew your food. It's not exactly the most exciting thing to say to patients, and it's not fair. And you have to say, well, it's not what some other patient, it's not what some other people can do, but this is the kind of stuff that works. You eat slowly, you concentrate on it, you're mindful, you enjoy the food, and that itself will mean you'll be satiated better, you'll be able to eat less. And it's those kind of characteristics. And if those kind of things are not being built in, that's the problem. We end up weight just incrementally goes up. And
Correct.
yeah, if you
And
without that change, it doesn't work.
yeah, and I think that's essentially the point I was making, that it's the relationship with food essentially that needs to be changed, which is what you're saying, just differently, that, it's the mindful eating and
Mm.
engaging in healthy lifestyle activity, which many of us already know. Our patients are already aware of that. They've tried that many times. But just on the another note that you mentioned about the head-to-head study, there was another head-to-head study that was done by the American Society for Metabolic and Bariatric Surgery, comparing surgery costs. And we're just talking about costs at this stage, costs of surgery, gastric sleeve surgery, gastric bypass surgery, with the duration for which Wegovy and Mounjaro have been, sort of the duration for which they're given and the cost of it. And, I was surprised to find that the crossover point, which is, where the costs of Wegovy and Mounjaro cross the cost of sleeve, is at 8 months. So the cost of this is in US, by the way, which is far more expensive than what we get the medications over here. And the cost of bypass, the crossover point was 14 months. So you do a bypass, whatever cost that is there. This is for everybody who can understand this in a more simplistic way. And you take Wegovy for 14 months. All right. That's the similar cost. Beyond that, whatever you're paying for Wegovy is over and above. Yes, you have broken it down into small installments. So it was quite intriguing for me
Mm.
to say how the researchers had sort of calculated this and shown it in a graph. In fact, tomorrow I'm having a GP education event, and there is a bit of a debate going on between myself and the other endocrinologists. So we're kind of putting this point forward. But you're right. These studies, more of these will come, and I think the beauty is that they bring attention to the different perspectives and different aspects of management and the gaps that are there, so that we can find better ways of filling those gaps.
I mean, that's a fascinating study, isn't it? And you would like that particularly, Arun.
I I'm using it as one of my rebuttals.
Um,
I think
but
the only thing to think
sorry,
about
Don.
is the hope in the future that when the medication comes off patent and become more easily available in the next 10 years, it's still going to be sort of staying similarly as effective as it is, and it'll be a lot more accessible for patients as well. So I think that's very exciting future for me to see.
Yeah, absolutely.
Yeah.
But Don, on the other side of that, I don't know if you saw in the recent headlines from the UK, was there was the largest sort of, seized by the police authorities for illegal drug. And guess which drug it was? It was Ozempic. The the largest
We've had,
Dear,
haul that
yeah. I think
dear,
I'm
dear.
sure Roland had a similar issue down in Tasmania as well during the COVID pandemic and the Ozempic shortage. There has been a lot of compounded Ozempic that came from European countries that have been shipped around in Australia. I'm glad that the TGA stepped in and put a stop to it. and then the pharmaceutical company has been game enough to bring up the stock back in the market. But that was a very horrible 12 months for us as doctors to navigate the patients. Oh, but they can send it to me in my mail with the medication that works. So it's like, yes, it's not quite the same thing. But yeah, I think that if there is money to be made, I'm sure there will be a lot of dodgy ways of people trying to make it as well. So
Yeah, exactly. Now, there is one thing that I want to touch upon from both of you, which comes up time and time again, and that is the side effect of these medications, and one side effect in particular being muscle loss. Everybody is talking about it in some shape or some form. Certainly, there is a lot of sort of publications and research around it saying yes, it is not really a concern, and for some surgically biased journals are actually saying yes, it is a concern. So, what are your views about it? I would like to ask both of you individually. Roland, I'll start with you. Do you get this asked very often? Is this something that is a concern for patients?
It's certainly an important issue. Interestingly, most patients don't ask me anything about it, and I'm the one that's raising it with patients to talk about their muscle mass and function and so on. And it's part of why are we trying to get patients to lose weight? It's not about a number. It's not about fitting into certain clothes. Much nice as that would be, it's about their health. And as a doctor, that's why I'm treating, because I want to reduce metabolic risk, cardiovascular risk, want to get them more mobile. I don't want them to lose weight and then not be able to get around. It was interesting. Fellow that lost the 60 odd kilos and starting at 310, he was not interested at all in doing anything with our exercise physiologist. And so he came back after 3 months for his first body composition reanalysis. And we have one of these Seeker scanners, bioimpedance. And the weight loss, half the 60 kilos, was muscle mass. It was a bit of
Mm,
a disaster. And I think
yeah.
probably seeing that then encouraged him and he started to engage. So my take on this is that around 20% or so of weight loss normally, whether it's dietary or with GLP-1s, is associated with is muscle loss. That's the typical data that you see in most of the publications when they've looked at DEXA scans and they look at how much muscle has been lost, mass loss, then it's around about 20%. And that's why we're all engaged in trying to get people to engage with the exercise physiologist and or go to the gym and get their and reduce that. And you certainly can. You can get some patients who remarkably manage to put muscle mass on. You have a lot who
Despite being on
just
GLP-1s?
despite be on GLP-1s. Now that's a small number,
Yes.
but maybe that's only 10%. But you can certainly reduce that 20%. So I take it's a win if with the multimodal management that we try and encourage people to do, they are losing 10% of their weight as muscle. That's what I'm aiming
That's what
for
you're
if we
aiming for. Yeah.
if we possibly can. And I wouldn't blame GLP-1s. I think it's just a marker of you're losing weight, and GLP-1s are more helpful and more dramatic, as Don's been saying, because this is a hormonal chronic condition. Then you lose more weight than you did when you just went on a diet. Um, so I don't think GLP-1s are the baddies here. It's simply weight loss. We can mitigate some of it by encouraging the strength training.
Yeah. And I think what you said is also very important for anybody who's listening, that it's important to get your baseline tested using a scan, either a DEXA scan or the types that you're using, the bioimpedance ones as well, which are more readily available, but get some measurement done as to what is your starting fat mass, muscle mass, so you can measure it and assess what are you losing more of. Don, your views about it?
yes, so definitely I agree with Roland. And I think losing muscle mass while doing weight loss is not a GLP-1 thing. It is a weight loss thing. It is natural when whatever way you lose your weight, with a dramatic weight loss, say 5-10% over 6 months' time, either being surgery, medication, or pure diet, you will lose some muscle inevitably. So it is very important for the patient to be aware of it. And some more so than others, especially when they're a bit elderly, they're a bit difficult for them to put the muscle mass back on. And also use this as a incentive for the patient to actually to understand to get more protein in their diet, therefore help them to take less calorie in their day-to-day diet, highlight the importance of protein, and also using the muscle as well, just encourage them to do some more exercises as well. So I think that's very important. It's definitely one of the big topics I spend a lot of time with my patients and reminding them and encouraging them about the muscle loss and the potential for muscle loss. It is not a, it is, and yes, and it's definitely not a medication thing. It is just related to the weight loss. And in terms of getting the muscle mass measured, unfortunately, there is no perfect measurement on it,
No,
and there's definitely no easy way of as simple as testing your blood pressure, just hook up a machine and you get a measurement. It's a lot of different machines and involved and the mass and the percentage of muscle mass and what's in the muscle mass that you see. Is it fat in the muscle as well? And when you're losing weight, are you losing the bulk of the muscle, but the functionality of the muscle still remains? If you think about Wagyu beef, you're losing the fat in between the muscle fibers, but then the muscle will still, although they shrink down, but they're getting stronger because they not moving with so much fat in between them. So it's a lot of debates about measurement, but definitely if you can get access to some biometrics, then that'll be very good data. And also more importantly is functional strength as well. So we are start using something like a grip strength as another factor of testing how well your muscle is and or how functionally your muscle are or how strong your muscle is, and to make sure that doesn't get lost when you're losing the weight as well. So so there's definitely very important to keep the protein up, keep that in mind, and try not to try using exercise and try not to try to maintain the muscle mass as well. So yeah.
that's good, Don. And I think, yeah, you're highlighting the same point around measurement. Do some form of measurement. Yes, we get it that not every form of measurement is accurate. And in fact, in this day and age, I've seen plenty of AI-enabled apps who will just scan your body from an iPhone and they'll tell you this is your body composition. Now, I don't know how accurate that is because, like, medically speaking, we still regard the DEXA scan as the kind of gold standard as a measure of, for research purposes. But keeping that argument aside, I think the message should really be do some form of measurement, some form of biometrics will just to make sure will help you preserve muscle as much as you can. Beautiful. I've got one question from the audience. Don, I'll give this to you. That GLP-1 in menopausal women results, any differences? Are there specific issues? Are they a separate sort of category of complex patients? How do you have that conversation?
Yeah, look, I think menopause is a very difficult phase for the women, for unfortunately for everyone to go through. Some people suffer it more, some people suffer less, and unfortunately, some of the issue you get from menopause, like the mood swings, the hot flushes, the irritability, the stress, and the not able to sleep well at night, really make it difficult for them to focus on their diet as well, and therefore that's a very easy period to put on some weight. So definitely my suggestion for people who are going through menopause is definitely having a conversation with their GP to fix their menopausal symptoms first as well. And definitely GLP-1 is a very useful tool in this period to take some of the hunger away from the equation so that they can focus a bit better on other things. And unfortunately, and the other thing is physiologically going through menopause, women do lose the estrogen, and not only the estrogen gives the protection of the heart, it also sort of reduces your base metabolic rate. So if you don't change your diet, don't change your exercise schedule, you naturally will put on some weight because you're starting to burn a little bit less and less comparing to what you used to. So I think it's another time for people to actually to recognize that and doing the adjustments themselves. And it's often that, yeah,
I
And that's
think,
where GLP-1 can come in to help as well.
yeah. I think, Roland, it's a well recognized observation in our clinics as well that we get middle-aged women who come, and this is the one thing that they say that I started gaining weight since I hit menopause. It's a very sort of it almost is physiological, right, to be considered that way. What are your views around that particular sort of age group?
Hmm. Uh, I agree with everything Don said there. The resting energy expenditure, menopausal women, the rates go down significantly at menopause. So that's things like the incidental activity, the fidgeting, the basal energy that's expended is much less. And so, as you're saying, Don, you could be doing exactly the same thing, but your metabolic rate's gone down, and you stop doing some of the things that you were previously doing. And although the weight itself may not be massive, it's predominantly fat mass that you're putting down at menopause, and it's central. So I think so as you say, so I mean that's really just a preamble saying that there's a whole bunch of physiological reasons why this happens, and it's absolutely the worst and most difficult time. We talk about people's weight journey, and one of the most frequent things we talk about is childbearing and menopause, because they're two of the most difficult things in terms of regular metabolic rates and energy expenditure changes as time goes on. So I use GLP-1s absolutely in this area. Uh, Protein's really important. Exercise physiology is really important. And sleep's really important. And I absolutely not even as an endocrinologist, you would think I should know about so-called women's hormones, but I end up referring lots of these patients to uh, female GP specialists who can do examinations, who are much better than me at manipulating some of these hormones. I can prescribe estrogen and progesterone, and I can give you a view on it. A lot of them are an awful lot better than endocrinologists at doing it. And I always recommend patients to go and see a GP specialist about their menopausal hormone replacement.
It's so intertwined, isn't it? That's the important thing. And I think what I'm hearing from both of you is that it's really about getting a holistic view around a multimodal approach to it, not just giving GLP-1s, because it is a challenging time, but that challenge can be managed if it is addressed in that multimodal fashion, addressing the needs for the nutrition, sleep, exercise, and all of that. Gents, I must say that I've really enjoyed this conversation with both of you, and I know we are coming to the end of it, but I think I want to just wrap this up by a key takeaway that I want to ask each of you. What would be the key message that you want to give to your patients besides being on GLP-1s and trying GLP-1s for all comers almost is what I heard is what I have gathered. But I think how can they use it? What is your number one guardrail that I would like to ask each of you separately? What would you tell to these patients? So starting with you, Don, what would you say to them? Key takeaway.
Yeah, look, I think the key takeaway is that definitely having that conversation with your doctors, either being your GP, bariatric GP, or endocrinologist, having that conversation is a very key thing. And then setting up the right realistic goals. And the other key thing is that the medication is there purely to suppress appetite, and it doesn't necessarily definitely relate to weight loss, and it's still only one simple tool on a very messy equation. So although it's a very strong tool, but you still need to have all the other things in your life working towards it. Things like your dietary change, getting a bit more active, getting onto the proteins. So I think and that's probably the other key thing is that the medication is only part of the equation, and you still need to really work on it as well to achieve a good result.
Great. And Roland, what about you?
My take home is always to start the conversation with saying to the patient, this is not your fault. Do not believe what the world tells you. Do not believe what your friends are saying or uh, is saying. You have, unfortunately, you have very little control over your weight without the help of other medication. Obesity is a chronic disease. Do not believe that you are doing the wrong thing. The number of people who come in and their heads are bowed down, saying, "I've done it again, Roland," or "I'm the problem. I've fallen off the wagon." It's this internalized weight bias that we find is so. It's like a cancer where you believe that you are the problem and then you can't change. So to go back to our business, you are a brilliant being. You are not the problem. Believe that this is a disease. It requires, like all conditions, medical therapy. Do not be embarrassed about using this treatment. It is highly effective. And this will, we hope, make you a healthier, happier being. And we'll be behind you the whole way, hopefully with this multidisciplinary team. But please believe in the program and believe that it can get better. And you are not the problem. My takeaway.
That's beautifully said, Roland. I almost see you as the next Tony Robbins of the medical community, you know. That's your next career move, I must say that. That's
Thank
really
you.
well
Thanks,
packed,
Arun.
Roland. So, look, with that, we wrap up today's deep dive into this GLP-1 medications and asking the experts about it. And I think there's one thing that if I have taken it, not only as a medical professional, but also as somebody who's been sort of, exploring what is the place of different treatment modalities, I feel there is no single magical fix. It requires a commitment from the individual. Our job as health practitioners is to guide individuals in a safe, effective manner. But as Roland has said very beautifully, also the individual needs to recognize their own power. And that power comes when you are empowered with evidence based information delivered in an empathetic and a sort of professional manner, so you understand that this information that is being given is allowing me to empower myself so that I can take action. So with that, I want to thank both you, Don and Roland, for taking out your time for having this very engaging conversation. I'm sure there'll be many more questions, but I think we will leave that for another day. I want to thank both of you for taking out the time and sharing your wisdom. Thank you both.
Thank you.